had the chance to as yet to use this QR code to download the session PDF that we'll be using. So basically this PDF is something that is an interview template that I made. I have used it since I was a medical student, and to this day still use it in residency. It has been incredibly helpful for me in being able to diagnose and treat patients. A couple of ground rules, guys, feel free to make sure that you're muted on your mics. There will be Q&A at the end, so then we can kind of just like chill, relax, sit back. I'll stop the recordings then, and you can feel free to ask questions. And if you'd like, I mean, for now, it's actually totally fine to not have your cameras on because I can't see you anyway because of the way Blue Jeans is set up. But then when we're doing the Q&A, it would be great to be able to see you guys' faces so I can know who it is that I'm talking to. So here we go. We're kind of just jump right into this. So I want to start off with just letting you guys know, I hope that you are here for the session called How to Earn Clinical Honors on Your Psychiatry Rotation. And I want to just emphasize, so I'm going to focus on the clinical aspects of things. I think I can 100% say that where I kind of shone in medical school was the clinical side of things. I mean, I did fine with the exams, but you probably could honestly get better exam advice from somebody else. I am here to give you the advice on how to clinically excel on your psychiatry rotation. So an important disclaimer that I'm going to just share with you all. So I want to let you know a reminder, this webinar, it's to educate and to inform you guys on the best practices to provide optimal patient-centric care. So even though, I frame this in the way of thinking about you guys getting honors, because, as students, I know that that's important. At the end of the day, by providing patient-centric care, that is the best way to line yourself up in any rotation to achieve clinical honors. All of that being said, have to put in some legalese here. This has nothing to do with my residency training program. This is all me, just kind of wanted to do this. I really love education, helping folks. So this is just kind of me doing this on my own, wanting to be able to connect with the folks who are interested in psychiatry or who just want to be able to do well in psychiatry. And then the last thing, obviously, I'm not liable for your grades at the end of the day. I'm glad that you are here to participate in this, and my goal is to help you to achieve honors. But if that's not something that happens, I'm sorry, and we can talk. You can hit me up, DM me, whatever, email me to see what you can do to improve for the next rotations that you have coming up. All right, so one of the most important parts, and I really just kind of want you guys to kind of sit back. If you have your the templates that I made, the PDF templates of the interviews for both new patients as well as the follow-up patient interviews, kind of take, if you want to annotate on there, whether you're doing that on your laptop, doing that on a piece of paper that you've printed out, I want to just kind of walk through what I have created. So this is the document, kind of like a big picture screen of the document that I made. And as I said, literally to this day. So I made this in, what year did I make this? I made this in 2018, something like that, when I did my clerkship rotation. Yeah, it was 2018. And then I've obviously adapted it over time as I've learned more, as I've kind of adapted my interview style. I've changed this form, but it's more or less the same template that I've been using since I was in med school up until now as a resident. And I will say, I've always gotten really good feedback on how I interview my patients, how I present my patients. And a lot of it is because I believe in being systematic. This paper right here, I literally printed out front and back on one piece of paper every time I go into an encounter, whether I am in the emergency department, whether I am on an inpatient unit, whether I'm doing consults. This piece of paper allows me to make sure that I'm being thorough, and it helps me to make sure that I'm organized so that when I'm interviewing a patient and then presenting the patient, I don't miss key information, and I'm also going in an order that attendings are used to hearing and that will allow you to communicate effectively. So one last chance, in case you missed the QR code before, in case you missed all my emails that said to download the template, here's your last chance with a QR code to download the template so that you can kind of follow along with me in looking at the document as a whole rather than in the pieces I'm going to kind of break it up into now. So let's start off with kind of just the general history, right? So in a lot of ways, a psych interview is honestly not that different than a typical medicine interview. You still have the same key components where you're thinking about the history of the present illness. So you're thinking about the problems that a patient's coming to the hospital with, and how is it then that you will help them in the future by understanding what has been going on in the past. And you'll also want to make sure to get a review of systems. So I don't know what mnemonic you guys use to collect a HPI. I have always used the old carts one. I don't usually write it down here, but I'll kind of just go through it if I can even remember it off the top of my head. But for HPI old carts, so I use old is for when did the symptoms start, onset. L is the location, which doesn't really apply so much to psych, but more so of like what type of symptoms is the person having. D for duration, C for characteristics, A for aggravating factors, R for relieving factors, and then cards T for time course, S for severity. So I still do that stuff, and I think now that I've just been in practice, like I don't have to go through old carts, but that's just the information that I want to make sure I have collected in the HPI for each of the symptoms that someone is complaining with. So if someone comes in with depression and anxiety, then I'll do old carts for depression first, then anxiety. So what I have here now and before I skip this, so patient goals for admission. That to me, I think that is in and of itself right there. Like if you collect that as a med student, that already puts you above your peers, because that is showing that you are centering what matters to the patient in your treatment plan. Because I had a patient once, and this was like a few months ago, she came into the hospital depressed. And I think typically our first thought is patient presents depressed, put them on an antidepressant. But because I always make sure to ask my patients, like, what is the goal that you have from being here in the hospital? She said she wanted to feel better, but she also said she did not want to be started on medications. So I would not be providing her proper care if I just try to shove antidepressants down her throat. Instead, what we did was we walked through a plan of how she could be started with a psychotherapy program outpatient. We talked about coping mechanisms that she could develop on her own to help her to feel better. We talked about alternative treatments, so whether that be things like exercise, yoga, acupuncture, other types of remedies that she was more likely to actually do on a regular basis instead of taking antidepressants, which she didn't want to do. So if you as a medical student were to actually ask your patient, what goals do you have for this admission? Or what is it that you want us to do for you? Or what are the symptoms that you want us to target most? What's bothering you most? If you focus your interview on that, if you focus your care on that, you will 100% stand out from other medical students, because it's honestly not really that commonly taught, but it's so important to making sure that you're aligning with your patient for what matters to them, because ultimately we're just a conduit of being able to provide the care that our patients ultimately will engage in. So after that, then you once you get the story, I kind of like to kind of fill in the blanks of other symptoms that were not mentioned by the patient. And honestly, as a medical student, I would say I did kind of do this checklisty because when you're learning, you kind of just want to make sure you don't miss stuff. But I'll give you a tip and trick if you're ambitious and you want to kind of try something a little bit more advanced. When you're collecting the review of systems, a really good way sometimes to collect information is to ask someone to tell you what a typical day is like for them. So with that, I'll ask someone, hey, like what time do you wake up in the morning? Do you have breakfast? Do you go to work? Like I'll have them walk me through all of the aspects of their day. And by the time we have done that exercise, I've learned about their mood, if they're sleeping, if they're eating, if they're doing the things that they care about, what's their energy level like? Are they taking naps? And I can gather that information without having to say, how is your mood? How is your sleep? How are you losing interest? Do you feel guilty? Because that doesn't really flow so much as like a conversation in the interview, which is what I aim for. So as I said, starting out, the checklist is fine because that is also how I started. But over time, like let's say you're at the sub-I level, if you're an MS4 who's in this session and you're trying to do that interview, right? Like you're doing that interview to get a good letter of recommendation for residency. That's a good task or a good technique to try. So the way I have these listed, and I'm not going to go into like a ton of detail because that's more content based and today is more of like a structural kind of day. But the first column of these symptoms are, I hope you guys kind of guess it, these are the SIGI caps related to a screen for depression. The middle one is a screen for Well, actually, let me ask y'all. I'm going to jump out of this so I can actually see what's going on here. What do you think that middle column, those symptoms are screening for? You guys can leave it in the chat. Yep,
personality disorders.
Yep, mania, exactly. So that's what that middle one is for. And just as a reminder, if anyone has their mic on, if you could turn it off, that would be great. So the middle column is to screen for mania, because you always, in any patient, you want to do a quick screen for depression, quick screen for mania. And then, so let's see, the first three items of the right-sided column, what is that screening for?
Schizo.
Yep, exactly. So, and I think we'll even so what I like is some people have said schizophrenia, Madison has said psychosis, and I want to phrase it as psychosis, right? Because remember, when we're collecting information, we're not actually making a diagnosis as yet. We're collecting information that will give us information about signs and symptoms. So, for instance, like that middle column is for mania, but mania, if someone has mania and psychosis, those are going to be two very different diagnoses. So just being careful that you're not necessarily screening for a disease as much as you're screening for particular symptomatology. And then let's see, the rest in that column, however many there are, the rest in that column are associated with what types of disorders? Thank you, Trish, for sharing that. I wasn't sure who it was. But do you guys have a sense of the remainder of the items in the right column? They all are a similar type of diagnoses together. Nope. All right, no worries. I'll give you the hint. So these are all actually commonly associated with anxiety in a lot of ways. So PTSD in many ways is thought of as an extreme anxiety disorder. Stressors can lead to anxiety, can also lead to depression and mania. Trauma and abuse often can relate to anxiety as well. OCD is an anxiety spectrum disorder, ADHD. That one less so. But these are all things that we want to screen for when we're seeing patients, asking about history of these things, also asking about symptoms that someone would experience if they were to have either of these types of presentations. So now that we kind of have a sense of the initial presenting symptoms and the presenting situation, now it's time to kind of get into some history. So again, my goal is always to try to make this as conversational as possible, but sometimes you just have to ask the questions. So when it comes to past psych history, this is a section that's going to be quite different than your typical medical interview, right? Because typically, honestly, medicine doesn't really care that much about the psych history, whereas a psychiatrist, that's one of the main things we care about. So some of the things to think about, we have onset of symptoms. I always ask, is this the first time you're depressed? Have you been depressed before? What diagnoses do you have that you're aware of? Have you been on meds? Have they been helpful? Have you been compliant? All of that information is incredibly helpful. Have you previously been hospitalized for a psychiatric reason before? Do you have outpatient care, case manager? Really, really important. You always want to ask every patient, even if they did not come in with depression or suicidality, have they ever had a suicide attempt, or have they done self-injurious behaviors like cutting or burning? Always want to screen for safety in any of our patients. So some of the other things, so we'll also do a substance use treatment history. So again, in psych compared to medicine, we'll go into even more detail. So some of the things that matter for us, especially for alcohol and for benzos, is thinking about withdrawal history that has been complicated by things like seizures or by delirium tremens, for instance, because those are things that can be life-threatening withdrawals. But then also, things like when did they start? How much do they use? When was the last time they used? Overdose history. These are all things that are incredibly helpful from a psych perspective, especially because we have a lot of let me rephrase that. There are treatment options for some of these substance use disorders that we can offer medical treatment for. So kind of getting a sense of the severity of someone's illness kind of helps us direct which treatment path might be best for a patient.
Hey, popping in just for a quick commercial break to remind you to subscribe to my channel and like and comment down below if you're liking the content so far. Hope you enjoy the rest of what's to come because there's a lot of good information in store.
And then going into more history, so kind of your typical past medical history. Are they seeing a primary care doctor, other healers, allergies? Family history, we kind of tend to target and really specify mental illnesses in the family. So asking like specifically, do you have history of bipolar, depression, schizophrenia, substance use disorders? Do any of those exist in your family? And then if anyone has had treatment before, what have they used? Has it been helpful? Sometimes that can just be good information to have, because if someone says like, hey, my mother was taking Lexapro, for instance, then they might have a greater affinity towards being able to feel comfortable starting onto antidepressant. And sometimes, I actually don't know off the top of my head the studies about this, but I think sometimes they've seen that what works in a family member might actually also have increased efficacy for a relative. So that's one of the reasons we ask about which medications a family member might have taken. Social and developmental, again, this is a section that we tend to go into more depth compared to a medical, definitely more so than a surgeon, when it comes to getting our information about patients. And I'm actually on a child psychiatry consult service right now. And I thought like as adult psych, we got a lot of information. Like on the child side, we're asking, what grade are you in? Do you have pets? What is your pet's name? Like we are getting to know everything about these children. So here it shows you childhood education, social support. And this is actually a really, really, really important part of the history, because a lot of outcomes in mental health illnesses are related, in fact, to social factors. So when we're thinking about the education that a person has, or childhood traumas, or social supports, income, all of these things impact the ways in which someone is able to get access to and maintain access to care, or even their willingness to get care to begin with. So if we're not getting information about this, you are not fully treating your patient. And one of the things as a med student, again, because you guys tend to have more time, like let's say you're limited in the initial encounter that you can't get all the information you want, you have time to go back and make sure that you're filling in the history that's important. Military history is important because the vets have tons of really great access to mental health care. And we always try to get vets to really lead into utilizing that care because they have such great access compared to a lot of the private providers or even public providers that are outside of the military. Spirituality. So if you follow me on social media, you know that spirituality and mental health is something that is really important to me. And what I've found in my research is that even though in medicine, people in medicine tend to be much less religious or spiritual than the general population, because actually most of our patients are spiritual or religious, this I have found, I have started to integrate this in the past few months to check spirituality for my patients. And I would say so far I'm at about 60% of the time, patients want to interact with a chaplain, or they share that their spirituality is a really important part of their lives, which is important for us to know when we're thinking about healing and like the cultural nuances that we're providing for care. The remainder of here, so I have pertinent labs. So in psychiatry, we do get labs. Contrary to popular belief, there are a lot of labs that are really important for psych. So make sure that you are paying attention to those labs when you are kind of seeing patients. I'll throw out just a couple quick examples. So for an initial psychosis eval, for instance, if this is a patient with new onset psychosis, you might want to make sure the patient has a TSH, so a thyroid level, B12, RPR. These are looking for other causes of psychosis other than psychiatric illness, because there are organic or medical causes of psychosis that do exist. The mental statics exam, so that is thinking about, basically, this is the physical exam of psychiatry, will you say. And I won't go into the details because honestly, that could be a whole hour lecture on its own. But I'm hoping, and you guys can let me know in the chat if you would be interested in me going into more detail in different sections in future sessions. But here, basically, I want you to at least know the names of the different parts of our exam. Coming out of an interview for psychiatry, you want to be able to create a visual picture of what this patient is like, and that is what the mental status exam aims to do. Last but not least, so this is definitely something I am actually planning to do a separate session on. So I don't know, let me know in the chat if you have ever heard of the biopsychosocial spiritual formulation. All right, cool. Thanks, Kristen, for letting me know that you're interested. And for other folks, have you guys heard of the biopsychosocial spiritual formulation? No, okay. All right, cool. So truthfully speaking, this is not something that is, well, first off, I learned from one of my good friends who is also in psych, and she's in psych, or she's a med student going into psych, and she's in California. Even her med school hadn't talked about the biopsychosocial spiritual formulation. So it's one of those things that's not always taught, but I have found it to be an incredibly important way to conceptualize a patient. Meaning, when we think about the biological, the psychological, social, and spiritual aspects of a patient's humanness, of all of the things that are related to who this person is and why they have presented to you in whichever clinical setting, when you think of all of those different components together, it allows you to create an assessment that is much more targeted from a diagnostic perspective as well as a treatment plan perspective. So as I said, again, like similarly to the mental status exam, the biopsychosocial spiritual formulation is something that and it is like when I'm working with med students on the units, I do a whole hour-long lecture on the biopsychosocial spiritual formulation because it's helpful in psych, but truthfully speaking, it is incredibly helpful regardless of what specialty you go into, because a lot of times, even in general medicine, if you're not paying attention to the social needs of your patient, you're not going to appropriately treat them because you might be providing a prescription for a medication that their insurance doesn't cover, or they don't have enough money to pay the copay for what it is that you are prescribing. So if you're not thinking about all those factors, you are not doing your diligence as a care provider. And my goal is to make sure y'all are doing your diligence as future physicians. And the other thing is, so for anyone here who has a sub-I coming up, I would say, so plans and assessments and plans, I would say for clerkship students, try your best. Like, that's basically it. Like, that's all that is expected of you. If you try an assessment, so you do your one-liner, your differential diagnosis, what you think treatment should be, you've done enough. Like, that's good for clerkship year. For the sub-intern, so someone who is now like really doing that month-long interview to get into psychiatry, you're going to want to go a little step beyond that. You're going to want to be able to say, kind of put your money down on a specific diagnosis. Which diagnosis do you think it is? Which medication do you want to prescribe? At what dose? Do you plan to titrate at any point? Like, you want to make sure that you are like running the show for your patients. And we'll kind of get into some more of those pearls a little later on.
Hey, it's so good to see that you've made it to the end of this video. Thank you so much for watching. If you've enjoyed it, please share with someone. And I think that you're gonna like this video right here because it's gonna help you to learn more about the topic you just watched. Have a good one.